Hello everyone, welcome back to Hot Seat. I'm Omid Moghaddas joining you from Tehran, and I'm so happy that I was able to provide this platform with a lot of my great friends, and I'm so honored to call me my friends because they are worldwide known international lecturers and great educators that accepted the invitation and joined me through this series of webinars. And today, a very, very dear guest, I have to say this, Professor Nabil Barakat is here with me from Lebanon. And why he's so important for me, because back in old days when I was on my last year of undergrad program, he came to Iran and he had an amazing workshop on sinus and PRF. And that was a time that it just came to my mind like this, that I truly want to be a good educator like this man here. So now after many years, I'm so honored to be his host. And I'm so happy that he accepted to join me in this series of webinars. So that is why it's very interesting session for me. So with that said, hello, Professor Barakat, and welcome to Hot Seat.
Hello, hi, Omid. I want to tell you that I'm very proud to be on Hot Seat too, and you hosting me. And I like the way you present, and that's why when Nadim asked me, I said, 100% I want to present.
Thank you so much.
Should I go ahead?
No, if you let me, before we start, I would like to have your CV. I know you are famous for the world, but as a tradition, I would like to have your CV for all of our audience. And the topic that Dr. Barakat will present for us is actually a very interesting topic. It's about ortho-integration, the alliance between orthodontics and osseointegration, which is a very, very interesting topic to talk about it. And definitely we will have a good discussion at the end. And Dr. Barakat is a former chairman at the Department of Oral Maxillofacial Surgery, School of Dentistry, Lebanese University. And he's an oral maxillofacial surgeon from Loyola Dental School, Chicago. He was the founder and chairman of the Department of Oral Maxillofacial Surgery at the Lebanese Dental School from 1982 until 2006. He's the president of the Lebanese Association of Osseointegration. He occupied many positions, among them president of the Lebanese Association of Osseointegration, president of the International College of Dentists, Middle East section, president of the East Mediterranean Association of Osseointegration, and coordinator of the postgrad program of the Lebanese University. He's the pioneer of implant dentistry and in Middle East especially, and also an international well-known lecturer. With that said, Professor Barakat, I'm so happy that you are with me on Hot Seat, and I'm ready for your beautiful presentation and looking forward for our discussion at the end.
Thank you, Omid, for these nice words. Let me get my screen. Okay.
It's good.
Omid, wherever I go anywhere, I always put the flag of Lebanon and the flag of the that's hosting me. That's why you can see your flag there.
Great.
My subject is implant and orthodontics, a symbiotic partnership. We really believe with Dr. Abu Jawde and the team that an interdisciplinary approach is important. Because people tell me, what's the difference between multidisciplinary and interdisciplinary? In multidisciplinary approach, you need a periodontist, you send them to the periodontist. You need a prosto, you send to prosto. Ortho, you send them to the ortho. What interdisciplinary is where we all meet after having the x-rays, the models, history of the patient, medical history, and then we make a decision. And I'm going to show you through that. The cases I'm showing, I'm not mine only, because you see the team that's with me. Okay, what's ortho-integration? Is the alliance of orthodontics and osseointegration. In 1992, we had a big meeting. In 1902, we had a big meeting in Beirut, and the chairman of the orthodontic department at AUB, the American University of Beirut, we made this lists of chapters. The first one is facilitating the orthodontic treatment planning process. The second chapter will be the prosthetic implant, and the third subject chapter will be the orthodontic implant. Facilitating the orthodontic treatment planning. Look at this case. Write the name of the orthodontist because he's been in my office. We worked together for 20 years. He sent me this canine. You can see it's unfavorably horizontally, anteriorly positioned. I took a CBCT and I could see that the canine was vestibular with a cyst around it, and I could easily remove it in a few minutes. And when the patient ended his growth, I put an implant. When I told him that, he was very upset. He told me that I underestimated his mechanical capacities, and he told me send back the patient. What I did, and since then, for the last 20 years, he didn't ever see a case, which I don't mind. Okay. 3 years later, I come to the office, I see the mother with the daughter crying, the mother crying with these pictures. He sent it to another surgeon, and when he heard that Barakat refused to do the case, he said, I can do it, of course. You know, 3 years of all what we have, intrusion of adjacent teeth, the tooth, the canine has moved and hit the apex of the central, and we see the deleterious effect later. Patient refused any ortho treatment because she had 3 years already and she was not happy. Therefore, I had to work what I had. I removed the impacted canine, grafted the area. A few months later, I placed an implant, and of course, the result was lousy because we didn't do any ortho. This is 3 years post-op, 4 years post-op. "12 years post-op." The tooth is getting darker and darker, and then 60 years post-op when she was 31. Therefore, the moral of the story is what? Any orthodontist who doesn't think implant in his treatment plan is a poor orthodontist. While this orthodontist who is in the team, okay, sent me this case with these x-rays, and he didn't send me the right one. He sent me just the panoramic. And he told me, please expose the right canine and remove the left. I told him why. Then he said, I forgot to send you these x-rays, which we can see an impacted canine with a coronal cyst, pericoronal cyst, with a of central and lateral. He said, why you want to expose it? Of course you can do it, but look what happened to lateral and central. Don't you have implant now? I said, of course I have implant now. He said, remove the canine, I'll do the ortho, and then you place the implants, which what we did. He came to the office, we removed the canine. We could see the tip of the central and lateral. And then at 15 years, the orthodontic treatment was finished. Now, how to assess cessation of growth? In the old days, we thought, but we know now that implants behave like ankylosed teeth. They do not move together with adjacent teeth. And then why we stop using the hand X-ray? Because it has its limitation, because the growth of bone in the jaw regions comes later that of the long bones. Therefore, the epiphysis radius fusion happens, and the patients, the jaws still grow. And from Bahat, at the meeting we had, we attended in where was it? In Los Angeles. Bahat said that women will continue to grow anteriorly and inferiorly, and the mandible anteriorly. And I'll show you cases now. Therefore, what is our protocol? We take an X-ray of the wrist, the orthodontist does it, to have an idea about the age of the patient. But then for males at 18 and females at 16, radiographs taken with the same X-ray machine, which is very important to determine cessation of growth. Therefore, between 14 and 16, you can see there's still this the patient between 16 and 17 go ahead and place our implants in this patient. But remember, superimposed serial tracings taken 12 months up to the same X-ray. Therefore, the orthodontist at 17 years and 6 months, he told me, go ahead and place your implants. Of course, you all know the atraumatic extraction. In this case, the thickness of phenotype often depends on the good phenotype and probably we have good bone around it. Now, how to avoid doing this, getting this, which on all my cases when I started in '86, I had, is because you put the implant too close to the buccal bone. And we know that the bone set the tone and the tissue is the issue. Therefore, what we teach our residents is that, first of all, you start with the precision burr, indicate the starting point. Then, with another burr, you start drilling in the you can see that optical implant position and prosthetic axis. Okay, in the old days, we removed the tooth and put the implant where the tooth were. And you can see how thin is the buccal bone. I mean, that's how we do. But it's very important to stress, we're not parallel to the palate. We're parallel to the palatal, to the buccal bone in a palatal position. It's an old case, you know. Therefore, we didn't have to place any bone substitute because we didn't know. But now in all the cases, we put some bone substitute in the space because they say that it retards resorption of the buccal bone. Then, with Nadim, with whom I work, I use a temporary crown of Ovid Pontic used to induce gingival carving, guided tissue healing. Okay. In all three, we had finished the case. Is it a nice case? Well, I'll say no. Why no? Because what did we do in this case? Did we do the crown? We didn't. Neither the surgeon, neither the prosthodontist. You tell me it's a nice case when someone show you a case 5, 7, 10 years after. Because we all know that after 7 years, problems start. Not, I hate to see presenters putting implant, putting the prosthesis and show it the next case. Therefore, especially in our part of the world, I insist on this. It doesn't show you cases. Few years after, don't believe what he says. Therefore here, and you're gonna see how I insist on this on all my cases. This is at 3 years. This is at 6 years. You can see a slight recession on the lateral. This is 10 years post-op. And you can see we have the beginning of a mesial drift between the canine and the lateral. We'll about it a little bit later. And then the last time I saw her was in 15 years post-op and 21 years post-treatment. And what do we have? We have the mesial drifts. On all cases, be it in the mandible or in the maxilla, we see that after the ankylosed implants, which is osseointegrated, we have a movement of the teeth anteriorly. Okay? Someone say it's mesial factor of forces to compensate for interproximal abrasion. This is the official explanation. But now that we know from Bahat that those continue, as I said, for women anteriorly and inferiorly, and for men anteriorly. Okay. Therefore, this is you see the case and you see the x-rays 15 years post-op. Therefore, what's the moral of the story on this case? Avoid heroic orthodontic attempts in difficult impaction, now that we have implants. What happens if we assess cessation of growth solely on an X-ray of the wrist? This is a case managed by Nadim. This is a patient with a treated cleft lip and cleft palate. We see transposition of premolar and canine, supernumerary teeth, interdisciplinary approach. We decided to extract the supernumerary teeth, and the orthodontist start palatal enlargements. Then with Professor Kayem, we did L41 expansion and bonding, and we ended this way. And Nadim, on all our cases of bone grafts, prepare for us a short guide before we put the grafts, so that we know that when we come and put the implants, we will place it in the bone, because use bone or to palatal or to buccal when we need it in the middle. Therefore, look what we got. Can we graft from bone to tooth? No. We have to graft from bone to bone. But if we graft from bone to bone, what will happen? We'll have to put our implant there. And look at the length of the crown. Therefore, Nadine suggested we extract the canine, and then we could put the graft from bone to bone. And then we can lower and place 2 implants in the lower part. And you can see that's what was done on the right X-ray. Then, as I told you, the same surgical guide that Nadim prepared when we place the graft, we use it as a surgical guide to place the implants. But don't forget, in this case, it's an old case in the 90s. We used to work only on X-ray of the. You can see the case. Soft tissue graft. And we ended like that 3 years after. It's a long way from where she was. Of course, it's not perfect. And then Nadim saw her 4 years after, and you can see extreme vertical deficiency due to continuous growth. And you can see residual growth and what he did post-prosthetic correction. You can see how the central and on the left were ankylosed and the teeth came down. Now, we're still talking about facilitating the orthodontic treatment planning process. Patient come to me with this X-ray. He's 11 in 98. What can I do? I have to ask for an orthodontic consultation. He has an impacted first molar, tilted second molar. Therefore, as we're working with a good orthodontist, the most important thing orthodontist is not just to fix the teeth, is to work about the profile. We have to have profile consideration. Therefore, in our part of the world, we have a convex face. Therefore, most of the cases, we have to do space opening and not closure. Because if you close the space, your nose will show up more. Therefore, the plan was space opening, headgear to inhibit maxillary growth, to correct facial convexity. I exposed tilted molar. We had no micro implant at the time, therefore he used a partial thing to do it. And then he uprighted the second molar. And when he's in the space, you can see the space he created to place ends, and he sent me the case to remove the first impacted, the first molar impacted. Now, of course, we don't work in 99. We don't work with CBCT. Therefore, you can see here, I can see that the nerve passes between the root of the second molar. You can see it on the X-ray on the right. Plus, when you see the panoscan, you can see that the roots are in the cortical bone of the mandible. And I know from experience that if I want to remove that tooth, I'm gonna break the mandible probably. I do something that I've been doing for 40 years, but American Association of Oromaxillofacial Surgery guideline talk about it a few years back. In case of the resultant extensive bone destruction leading to a fracture of the mandible or possibility of inferior alveolar nerve injury, we do something called a coronectomy or intentional partial odontectomy. As I get a lot of referrals of difficult impaction, usually I have every 2 weeks a case. Therefore, that's what I did. But you have to do this. You have to go 1 or 2 millimeters below the cemento-enamel junction. Why? Because the dentin is connective tissue, while the enamel is epithelium, ectoderm. Therefore, if 1 millimeter of enamel, you're going to have an infection. Therefore, you're going to be sure to be 2 millimeters below the enamel, cemento-enamel junction. I cut it so that I can get a 10 millimeter implant. Then we were waiting for the end of growth with space maintainer, placement of an implant, and Nadim did the crown. Okay. Is it a night case? Again, I say no. Show me that this works. Okay. Therefore, we are 0-1. This is in 98. This is in 2011 and 2017. What we could see, you see that the spaced opening and headgear to inhibit maxillary growth, to correct facial convexity, improved facial profile, and lower lip support. We can see clinically placement of the implant and the implant 13 years after, 19 years after. We can see X-rays when we started in 98 and when we finish in 2017. And you can see that we have no problem of the implant or at the apex of the implant. Therefore, then okay, I can say it's a nice case. But not the day you saw me just then Nadim put the crown. Now, aesthetic implants. We're going to discuss 3 chapters. Pre-restorative orthodontic alignment to optimize implant placement. This is the easy part. Orthodontics facilitate implant placement by creating adequate space, redistribution, and the surgical difficulty of incurred by the surgeon following orthodontic treatments. When I presented this in Paris a couple of years ago, the orthodontists were very upset because I said that the orthodontic treatment causes us surgical difficulty. Okay, when I started a long time ago to send the case to an orthodontist to open the space for me, what they used to do, they used to open the crown side and close the apex, and then I have the heart attack to slip an implant there. What's the problem? The problem is they taught them to put the brackets straight, so that they put the bracket straight, put the spring, and what will happen? The crown will open, the apex will close. But the idea is when I send a case to a good orthodontist, that he has to, the mesiodistal space is evaluated at 3 levels: a root apices, a dental ridge, and the crown. And usually I ask 7 millimeter. Therefore, how he does it? 2 ways. I learned this from the orthodontist. I'm not an orthodontist. He tilts the brackets so that the composite of forces make it that the whole tooth will move and not the crown or the apex alone. You can see a case here on the right, X-ray on the right, how it was and how it became. Now, sometimes he adds sectional rectangular wires with loops are used for additional divergence of the root to obtain root parallelism. Pre-restorative orthodontic alignment to implant place. I'll show you a simple case Patient came, retruded lips, class 1 malocclusion, she's for 8 millimeter overjet, and agenesis of 35, second premolar, lower premolar. You can see the pedodontist had placed a fixed space maintainer while gross, taking for the space not to close. Okay, and then when gross ended, the orthodontist had opened 8 millimeter and 6 millimeter the width. You can see it on the scan. In this case, the patient live in Dubai, Lebanese, but in Dubai, therefore we did immediate loading on this case. Provisional procedures placed the same day with reduced occlusal contact. And this is the final crown 2 months post-op. Unfortunately, I saw her 1 year after, and then she disappeared. Therefore, I never showed this case after that because I didn't have any long-term post-op. And in 16, the orthodontist called me and told me, imagine who came. You remember the case that went to the States, they migrated to the States? She's back. Therefore, he took pictures of her. This is 17 years after. She's 31 now. You can see the soft tissue on the crown, okay? You can see the view from up. 17 years post-op, and you can see the level of bone. Then you, okay, I can say, but this is a classical case. The only interest is the long-term follow-up. Now, case is more difficult. When we see that case, a minor form of hemifacial macrosomia, and by examining orally, you can see unilateral cross-bite and anterior bites. Why unilateral cross-bite? Because like ankylosis of the mandible, everything goes toward the ankylosed area. Hemifacial macrosomia, they have an absence and deficiency in the soft tissues. Okay, therefore everything went toward the hemifacial macrosomia. Therefore, we worked with the craniofacial because we needed bone, a lot of bone. And this is, look how thin was the maxilla when we opened. Therefore, we had to graft her buccally and palatally on this case. Therefore, two-piece osteotomy with down rotation, expansion of the maxilla, only graft from ilia. You can see this. You can see the bone palatally and the bone vestibularly. And then we went to the right side. Why do we see the screws? We know that in the maxilla, maximum 4 months you should place your implant, otherwise the bone will resolve. And as we know, the bone, the tissue is the issue. The bone resolved, the soft tissue follow. That's why we see the screw. She's a Lebanese nurse working in Saudi Arabia. She told them that I have to go back after years, and they wouldn't let her come. She came 7 months, 4 months, I said, isn't it? 4 months maximum, and in the mandible you can go up to 5. Therefore, but she came 7 months post-op. That's why we see the screw. Or she was undergoing orthodontic treatments. Therefore, I use immediate provisional implant. I place the permanent implants, and in between, I use, now that at the time we didn't do much immediate loading, and then you could not really do because he was moving the teeth, the orthodontist. Therefore, we put immediate provisional implants, 4 of them. And on it, Nadim made them bridge so that the orthodontist, like you see on the right, you see all the brackets and the bands. He could, when he moved the teeth, he can move from the bridge. 3 months later, I remove the implants, and place a temporary abutment. And you can see how still undergoing ortho treatments. And we did a temporary bridge so that still the dentist, the orthodontist, while moving the teeth, can remove from the bridge. Okay, this is while the ortho was going on. And in 02, she was like that. And in 07, when we finished case, she was like that. Now what about the lip? The left side of the lip. We know with Nadim from our experience of war injuries that if I inject collagen in this lip, what do I get? I get an everted lip and drooling of saliva. Remember Nadim? We did it once on a patient and it was a catastrophe. Patient was, he said before, I had saliva. No problem, saliva, all of a sudden it drools. Because when you inject collagen, what it does, it everted the lip. Therefore, we cannot do anything. We cannot compete with God. Patient was happy enough. This is 7 years. Unfortunately, as she had to go back to work, she said, stop the orthodontic treatment. We beg her to wait a little bit. I think she was getting married. I think I'm asking Nadim. I think he said yes. She was married and she wanted all the brackets off. This is 7 years after. This is 12 years after. This is 16 years after, I think, the last time we saw her. Nadim, did you see her after that? You never saw her. I think this is the last time we saw her. 16 years after. And what you noticed, I noticed that resorption of peri-implant bone around with native bone is different than when it's grafted. When it's grafted, you get this type of cratering. You know, can you see how it is? I've noticed this. I don't know if someone noticed something. This is 16 years after. And then you can see when she was 19 till she was 35. Okay, then of course I will say it's a nice case. Now, what are the surgical difficulties encountered by the surgeon following orthodontic treatments? This young patient, 12-year-old, when she went to the orthodontist, she had 10 second deciduous molar. She has a deciduous molar and agenesis of 35. Therefore, I haven't seen her before 18. When she came, and am I missing it? Oh. She came because she told in Paris, she was studying in Paris, and she had a space maintainer, and she asked a dentist to remove the space maintainer that was bothering her. And the space closed at 5.5 millimeter. Therefore, what do? She's 18. Should we start again ortho? She refused. Therefore, I had to use a narrow implant. But surprisingly, in this case, she had such a good oral hygiene that she never had any gingivitis or any inflammation of the papillae. This is 9 post-op. You can see her. This is 19 years post-op. Still smiling. Okay. And the last time I saw her was 23 years after, in 16. I had warned her that probably she's going to have problem with the papillae, but you know, sometimes do things you're not supposed to do and it works. And in medicine, they call it a joke. When you do something you're not supposed to do and it works, doesn't mean it all the time. But probably because I noticed she has a fantastic, she's a patient of Nadim. She has a really good hygiene, this patient. She's amazing hygiene, oral hygiene. This is 23 years after. You can see the small crown, but she keeps smiling. She's still smiling and happy. 23 years after, she's 35 now. Look at this case when ortho complicate our work. They perk left lip and palate, case of Roy Sabri, missing maxillary left lateral incisors, and total space closure. Okay, there's a missing lateral left lateral incisors and total space closure, plus a bilateral crossbite. Therefore, use those sectional rectangular wires with loops are used for additional divergence of the roots. But what happened in these cases? When the cases are buccally, the teeth are buccally placed, what happened? The more proclined the incisor, the more difficult to separate the root. As the crown are tipped labially, the root tend to converge toward each other, resulting in a wagon wheel effect. Like in the movies, like cowboy movies, when the wagon are filled heavily, what they do, they go inwards. The same thing happened with the orthodontic. Plus, like in this case, what happened? It results in deepening of the labial cavity, the natural labial cavity, and that we have in the lateral position. And this is, of course, increase the severity of the cavity, of the labial cavity. Then you need a bone grafts there. But look, and I admire this orthodontist, the parallelism between the teeth, between the lateral and the canine, on all three dimensions: root, bone, and crown. Implant placed. And we ended 2 years later with this result. Before and after, space opening, bone graft, implants. This is 10 years post-op. We published many of these in the American Journal of Ortho. Okay, this is 10 years post-op. This is 19 years. Yes, I guess 19 years. She's 57 now. These are a picture from the orthodontist to show me how stable the result is. 19 years, yeah. She's 47. She comes to Nadim follows. These are your picture. Roy. Therefore, as you see, Beirut is a small city. Therefore, it's easy to get a follow-up. You know what I do? I see most of my patients in social venues. But Mrs. So-and-so, please pass by. I won't charge you anything. Let me just have a look at what happened. Take an X-ray. No. Yes, of course I'll come, and they never show up. And when I see an X-ray patient, an implant patient in my office, I know I'm in trouble. When I arrive to the sitting room and I see a patient, because they will never come and follow up. Therefore, what I do, I call them, and even if they're rich, I know they're rich, I tell them, listen, never mind, I'll send you my driver. He'll get you, bring you over. You won't pay anything. We'll take an X-ray and we'll take pictures and send you back. And of course, shame and this going. That's why it's easy, because of the distances also, to get long-term follow-up in Beirut. You can see the case 19 years after. The orthodontic implants. If I knew that I was going fast, I would have did much more cases. I removed them anyway. We have OSSEOINTEGRATION single tooth implant are used initially as anchor units and secondary as prosthetic implant to replace missing teeth, and the use of temporary anchorage device as anchor units. Conventional implants. The first one who spoke about it was Robert, who was a very good orthodontist from Indiana. And those who, I never heard him, but those who heard them said he's one of the best speakers they ever follow. Look at this patient. She's 16. She comes to me because she has a tilted second molar. I know the family. Gingival smile. Horizontal impaction, mandibular second molar. Of course, I send her to the orthodontist. What can I do? And pass a missing premolars here and missing premolars up. Orthodontically, the orthodontist told me she has a skeletal class 2 division 2 malocclusion, impinging bite, severely retroclined upper incisors. Her uncle is a dentist known in town. He told his sister, "You want to save $4,000 the treatment of ortho in Beirut? Let me remove a premolar from the maxilla and a premolar from the premolar for my niece," and that's what he did. The skeletal class 2 division 2 is complicated by the previously maxillary right and mandibular left first premolars. Therefore, the orthodontist opened a space for me when she was 18. And maintain by a wire arch splint till growth ended. And Nadim does for us always a CT with a 3-point scan guide that help us in the direction of placement of the implants. Implant was placed. And then we found out that the crown was a little bit well, and compared to the upper, in relation to the upper premolar, it will be an oversized 34 crown. For what we said, we put a bracket on the temporary crown on the implants, implant supported, okay? And we use this to have an interarch palatal retraction of 24. Therefore, we took anchorage on the crown supported implant, temporary crown supported implant, to retract the premolar palatally. And we end the final case in 0-0 this way. When I see a case of orthodontist, the first thing I try to see is the midline, plus the parallelism of the roots. She was like that in 96. 4 years later, she was like that, 4 years post-treatment. 4 years post-treatment. We published this also in the American Journal of Ortho, 0-1. Then we saw the case 14 years after. We can see the premolar and the soft tissue around it, okay? And patient at 16, at 30, and we saw the patient 21 years after. She's 37 now. 20 years post-op, stable orthodontic treatment, stable tissue around the premolars. 21 years post-treatment. This is 20 years picture. You can see occlusally the premolar and the tissue around it. Now a second case. Patient had retained bilateral mandibular second, the serious molars, and agenesis of 35 and 45. We can see on X-rays, okay? The orthodontist finished the work, and he had 8 millimeter on the left and 7 mm on the left, sorry, 8 mm on the right, 7 mm on the left, and he had a lingual space thinner. Therefore, this patient also studied in France. She went to an orthodontist or a dentist, I know who did, and she convinced him to remove the space maintainer. When she came back to place the implants, this was 0, when she went. A year after, she was 7 mm on the right side, and 5 mm on the left side. Of course, we propose orthodontic treatment. Again, she refused. Therefore, interdisciplinary approach. We met with Nadim, we met with Roy Sabri, and say what we're gonna do in this case. And then we'll tell you what we did. On the right side, we have no problem. Okay, I have enough bone for a papillae. I have enough space for a papillae. Okay, on the right side, no problem. On the left side, the 5 mm one, I stacked the implants close to the molars. I was not drunk, my hand didn't shake. That was the plan. And when Roy saw the case, he forgot. He said, "You crazy? How do you put the implant this way?" I said, "You forgot what we decided. What we decided is to implant. The implant is inserted distally, close proximity to the second molar. Therefore, right side, you see no problem. Right side, no problem. Left side, you see how stuck it is in the space. And then at the end of osseointegration, a temporary gown, and that was used as an anchor to this distal drive first and second molar. You can see here on the right, intra-arch distalization. Okay. You can see notice the bone apposition after space opening by taking anchorage on the crown supported implants to distalize the second molar, the first molar and second molars. And now we have a normal crown, normal size crown on both sides. Therefore, in this case, we have orthodontics. Let's close. Should have. As we have a smart one. Okay. 4 years later, we have normal implant place in normal space. Therefore, in this case, we're going to show you the relation between orthodontics and periodontal problems and implants. Implants are usually used initially as orthodontic anchors and secondary as prosthetic abutments. I think, Nadim, it's your case also. Remember the lady from the Gulf area. Patient developed a dental problem added to the periodontal problem. You can see an X-ray. Dr. Jean-Marie Megarbani, who is also with our team, is a periodontist, and the orthodontist was Roy Sabri. What to do in this case? The perio took over, decontamination and surgical cleanup for the maxilla, placement of implants. We'll talk about it later on, why we place the implant this way. Okay. And orthodontics in progress with tooth anchorage. Orthodontist went on. Then we use the implant as orthodontic anchors. You can see implant on the right side is to distalize the molar, and the implant on the left side to lingualize the teeth, the whole block, the anterior block. You can see here the space created, look at side, how much space we created with the anchorage of the implants to have on the right side a nice size. And we implant, and as orthodontic anchors and prosthetic abutment, we place implant now. pre-treatment, post-treatments. And we ended like that in 09. Oral rehabilitation, influencing smile design, facial aesthetic. Unfortunately, this lady, you know, when they come to Lebanon, it's the center for plastic surgery for the whole area. Therefore, she went to see a plastic surgeon and look at the results. Post-injection, she was much pretty before, but she was very happy like that. She came very happy with the results, which I think is awful. Between Botox and fillers, she was much prettier before. And now in 11, we can see 01, 03 temporary bridge, 11 final bridge. And the X-rays 8 years post. Now the orthodontic implants. We use mini implants, we use mini plates, and we use palatal implants. Fortunately, I removed most of these cases because I thought I didn't have time. Therefore, the first case of Nadim, she had orthodontic treatment for 4 years in Saudi Arabia. And when she removed the bracket, she had the calcification all over the place, which I think she's the guilty, because probably she didn't have a good oral hygiene, because at her age, having such a carious tooth to be extracted 47. Therefore, Nadim, and it was his idea, we said, what do we do in this case? She's 17. She was 19 by the time we saw her. She brought us an X-ray extraction of 47. Okay. Therefore, he said, why we have to put an implant? Why don't we put 2 mini implants, 1 lingual, 1 vestibular, and track the 3rd molar? That was done. The idea always when you track, you have to put 2 implants. In the maxilla, you do 1 palatal, 1 vestibular. Because if you put 1 only, the tooth will turn sideways. And it took 6 months to bring the 3rd molar in place. And you can see both micro implant, lingual and vestibular. And as I said, it takes 6 months. Can we successfully use temporary anchorage device to manage skeletal deficiency? The answer is yes. Because I work with young orthodontists now, and they're very aggressive with the micro implants. Okay, they tell me put here and put here. Look at this case. This is she had orthodontic treatment a year ago, and she had finished, a year ago. She came to the orthodontist, she said, I have a canted maxillary transverse plane. She said, something wrong. My teeth are not parallel to my teeth, to my eyes. Therefore, you can see this, Nadim. A cant, yeah. Okay. Protruded incisors and lip, and you can see the cephalum. She had a huge cyst or abscess granuloma left first molar, and the other molar was not in very good shape. Therefore, the orthodontist decided, he asked me to extract the maxillary first premolars and both mandibular first molars. And then he asked me to put implants in the maxillary, right buccal teeth in the area, for intrusion of the whole buccal block to correct the cant. What I did, he did an intrusion of the molars and premolars. In this case, mini groove between maxillary first and second molar to intrude the maxillary right side, and closure of molar space and aligning the 3rd molars. Therefore, they advance the second molar and they advance the third molars. And we can see the result before and after. And we see the final result. Therefore, with micro implant, we can do a lot of skeletal changes. The end of the treatment was 24 months duration. And you can see the scan. And mainly you should see that the molar, there was no disruption at the apices of the roots. Another case came from Saudi Arabia. She had an open bite and anterior open bite of 5 millimeters. And she diffused, for the picture, the occlusion is class 3 molar and canine on the right, which shifted maxillary midline to the same side. The patient refused any surgical extraction option. Therefore, the orthodontist told me, listen, why don't we try microimplants like the Korean do? Therefore, 4 TADs were placed on the buccal and palatal sides to intrude the posterior teeth to correct the anterior open bite. On the palatal surface on the premolars and molars, we use lingual buttons were placed to intrude them all at the same time. Okay, we did this as you see it here on both sides. And you can see Dr. Ramzi Haddad, one of the orthodontists, doing the intrusion of the whole block, posterior block. Superimposition of the tracing before and after treatments showed the amount of intrusion of the molars. Not forgetting that the intrusion of the molars is one of the most difficult movements to achieve in orthodontics without microimplants. Post-treatments. Treatment 28 months. You can see before and after. And at the university, that's what they like to do. The patient is referred to a speech therapist. He was a myofunctional trainer who is giving to help correct tongue position during swallowing. Okay, I haven't seen the case, but the orthodontist that follows her tell me she sent him from Saudi Arabia 7 years after, in 16. This pictures, you can see more or less a stable occlusion. 7 years post-op. And very important is 7 years after, you can see how stable is the open bite, the closure of the open bite. And very important is no resorption at the apices of the molars. That's we worry when we do intrusion, is resorption of the apices of the molar. The last case, too bad I didn't realize I had time, I would have placed so many cases I have. The daughter of the Indian ambassador, she's 18. The first time I saw the picture, I thought it was LeFort-1 with intrusion, okay, and rotation of the mandible. But the orthodontist, a young one, told me, listen, why don't we try microimplants? I said, I try. I'll do whatever you want me to do. Therefore, you have excessive overbite and overshed. He asked me to place too many implants in the anterior region to intrude the anterior block, and place two implants, microimplant in the posterior maxilla, in the first, immediate to the first molar to retract the anterior block. That's what was done. And he's starting retracting the anterior block and up and backwards, and retracting the posterior part, posterior block. You can see the case when finished. Look at the overcrowding of the lower incisors. And we went in 2009 from this to this, 2011. Okay. Therefore, we were worried that how stable it is. Then she went into dental school because she was so happy what we did for her. She went to dental school in India. And she sent us issues. And I'll tell you why. This is 2017. I'll tell you why the orthodontist was not free. Because she didn't wear the retainer. He asked her to put the retainer for a year. She only used it for 3 months. Therefore, you can see slight deep bite relapse. Okay. And the reopening of the extraction site despite the bodily anterior segment. Can you see the space you have there? But what can you do? This is how we have 6 years post-op. Note the slight change in the upper arch form. Lower arch stable. What's the advantage of the TADs compared to conventional implants? No need of edentulous ridges, minimal anatomic limitation, ease of placement and removal, which is, I made it another color, the thing important for us, economic, treatment time reduced, simplified treatment mechanics, and immediate load application after implantation. Because I should have showed you some cases I did before someone talked about it, where I took anchorage on my crown supported by the implants to do correct overcrowding. And I was so worried about the loads. And then when I read later on about Roberts, I realized that the load is nothing, that the orthodontist put nothing compared to a load on a posterior implants of 800 grams. It's in ortho, it's only 200 grams. And in the posterior region during mastication, it's multi-directional. While in the orthodontics, it's unidirectional. Therefore, you know, you place micro implants, sometimes a week later it moves a little bit. You tell the patient, don't remove, keep the thing on, you know, and then 1 week later it becomes more stable, okay? Because stimulate osseointegration. The TAD has expanded the horizon of orthodontic treatment philosophies. They can bring about beneficial skeletal effects on the jawbone. Clinician can get similar and excellent treatment result without surgery. In conclusion, the specialty of orthodontics play a major role in the interdisciplinary manner of patients treated with implants. Using a team approach, the orthodontist, restorative dentist, surgeon are able to develop a treatment plan relying on the unique skills of each discipline. You know, we cannot finish any presentation on implant without talking about someone. When I invited P.I. Branmak to Beirut a couple of times, he said osseointegration is too important as to be handled by one specialty alone. An interdisciplinary dynamic approach in implant dentistry is recommended, where all the specialties are present. And then I cannot finish any presentation except thank you to P.I. Branmak. We are here because of him. And unfortunately, when I go to all meetings, someone called an orthopedic surgeon, someone don't even mention him. But I think we owe him a lot. If you're interested, we wrote the chapter in UCLA book of John Bumer, Fundamental of Implant Dentistry. And here's a picture of Bumer. This is Roy Sabri on the right side, myself, Bumer, and Nadim Abu Jawde. This is downtown Beirut. What you see behind is not a fire. It's a lit tree. There's a skyline of Beirut that still is intact. Thank you.
Thank you so much, Nabil. I have to say your presentation was truly valuable because we don't really see often people showing follow-ups more than 5, maximum 7 years. And in your presentation, we saw 17, 19, 20 years, 16 years, you know, and that was one of the most important things that I think you brought to us, because follow-up really shows us the importance of the way that how we evaluate our patients and our treatment for the patients. So first of all, thank you for that, because it meant a lot, and you know, it was unique. I can say that simply. So my first question was, because that was one of my challenges also. People ask, or sometimes our colleagues ask, when is the proper time for placing our implants in young patients? And you know, we don't have any specific number. And as you beautifully said, for example, we had something like wrist radiographs to evaluate, but as you said, you know, the growth of the jaws continues and it doesn't make any sense. And also we have to take every 12 months the radiography, so it's not practical. So do you think that, for example, we can say that it's safe to place implants in young patients after 20 years or no? After age 20? No?
Well, I cannot tell, but all I know is that this is the protocol we follow. We take an X-ray of the wrist just for have an idea about the age, the bone age. Then we do the superimposed tracing, and this is the safer thing. Okay, after 2 years, if it's stable, we go ahead and place our implant. Up till now, we didn't have much bad results. We've done it. And I just show you a part of what I have, because I told you I spoke at the Greater New York meeting. 3 hours they gave me.
Yeah, but for example,
aren't you surprised I use? Listen, aren't you surprised that I use only external hex?
Yeah.
I'm a Branmarkian, you know. I have good results. Why should I change? You know, all the other companies send me beautiful girls. Professor Barakat, please try our implant. What should I try? Okay, I have good results with what I do.
Yeah.
Okay.
Exactly. And that was also.
Plus, I'm scared internal. Plus, I'm scared with internal connection that in few years we start having tulip fracture because it's weakened. The company say no, it's hardened alloy, and but we start seeing, and Nadim can tell you how many tulip fracture seen now in roots. Because with rigid fixation, you know, with external hex, you have a leeway. And when I traveled with the PI in the 90s, we went to Tehran, to Cyprus, to introduce implant in the Middle East. And I remember he told me something that I will never forget, now that we have time. He told me a good system is a system where the mechanical part of the system is weaker than the biological one. That is, the mechanical part is the screw and the abutment screw. And the biological part is the osseointegration.
Yeah.
Therefore, when you have excess force, it's not the implant that breaks, it's the abutment screw and the gold screw and the abutment screw that will break.
Exactly.
People forget that.
Yeah, that.
And when I told Nobel this, they got upset. When I say that in meetings, they get upset.
Yeah, because also that was a good point to mention, that comparing the fracture of the abutment screw comparing to the implant, I think that was a biological point of it. So Nabil, one thing as an example, if the patient loses the central incisor at the age of 15, so and refer to you for doing something for her or him, so definitely we don't place implant at the age of 15. And for example, we can start taking.
I send them to Nadim.
Yeah. But after, usually you start taking the wrist X-ray at 18, right? The first wrist X-ray for this patient.
No. We take at 15, 16.
15, 16.
No, the first X-ray of the wrist, you see, of the wrist.
Yeah.
Yeah, at 15, 16 to have an idea about the age, the bone age. At 18, we are boys, and 16 for girls. We could take, as of 17, 18s, 1 year apart tracing, you know, okay? And compare, put them one on the other and compare if there's any movement in the anterior incisors or the pogonian. And if they move, we can go ahead and put the implants.
Yeah. So it's only based on the stability of the growth, depending on the radiographs. So you don't, for example, place the implant without having that evaluation.
No, we don't do this, and we have no problem and no price.
Great.
What does it cost to send the patient, wait 1 year, take another tracing, and superimpose it?
Great. And
I'm sorry I didn't show you much cases of microimplant.
Yeah, yeah, and one of the other things that you beautifully showed, especially the last part of the presentation, you showed a girl with the gummy smile, and that was a huge gummy smile. I think it was like 4 millimeter gummy show at least. So, and you treated the patient with TAT approach, only TAT approach. The case that you said that she went to India and didn't wear the retainer and some amount of collapse happened. So if this technique works that beautifully, I think it's underestimated by dentists around the world, because I haven't seen that kind of approach in many hands and many orthodontists. So what's your suggestion on that? Do you recommend it as a routine, or that was a specific?
You know, there's a textbook written by Koreans. Omid, there's a textbook written by Koreans about it, about the effect of the skeletal change, and that's what we got. We done and we tried it. Okay, I usually don't take the decision. It's the orthodontist who decides. You have to be a young orthodontist. Young orthodontists now that are coming are very aggressive, you know, and we have a lot of cases. I showed you 1 or 2 or 3, but we have plenty of cases.
And about the side developments,
I hope
sorry, I have one more question.
Go ahead.
Yeah, speaking of using orthodontics for building up the bone, what is your thoughts on that? For example, I have a narrow bone, and some people recommend to move the tooth inside that narrow bone and bring it back.
To move the teeth.
Yeah, move the teeth, yeah. So do you recommend it as a usual treatment?
Next time we'll show you some cases. Yeah. Next time we'll show you some cases.
Great, great.
We just finished a case with Nadim. Nadim, can you say a few words about it? Listen to Nadim, what he did, a nice case now we did.
Sure, sure.
Hello, Omid.
Hello.
It's a pleasure also to join in. Hi. So in the cases, for example, when you have 2 missing lower central incisors, instead of going, and you know, when you have congenitally missing central incisors, the bone in the anterior area will be very thin, associated with 2 frenum, one on the buccal frenum and the one on the palatal lingual frenum. So what we are doing nowadays is that we're removing the 2 lateral incisors in the site of the central incisors, thus bringing the separating the edentulus and bringing the 2 teeth in the edentulous space. On the back of the teeth, so on the distal to the moving teeth, you will be having building bone. So automatically, the site of the lateral incisors will be ready to implant practically with no need to graft the bone. And by this technique, what are we doing? We are avoiding the films. We are avoiding the area where you have a lot of calculus collecting on the implants. And we have better papilla management because there is no more 2 adjacent implants. There will be single implants, and it will be a marvel to look at. And hopefully we'll be able to show you these cases that we published.
That's a very interesting approach. That's a very interesting approach. Really looking forward to that also. Nabil, I have to say I thank you so much. You are truly an inspiration for all of us. I have to say it's not a compliment. And you know, it was again another lesson for us to follow our patients long term, to be able to exactly define the definition of success, and on the other hand, how we may fail if we don't follow up the patients to get important points from that. So with that said, I want to thank you so much for accepting. It was my honor, and I'm pretty sure all the audience have enjoyed your beautiful presentation.
Thank you. Thank you, Omid. Thank you once more.
Thank you. Hope to see you very soon, and take good care, my friend. God bless you.
Yeah, okay.
Bye-bye.